So, I've been trying to learn more about risk stratification, and the main takeaway seems to be that the model is a bit of a red herring. Like, sure, there's hard work to do on training an accurate model, but it's much harder to know things like what adverse event do you want to predict? Having the clinical operations in place to act on the prioritized list of patients that the algorithm says is most likely to have said adverse event, and being able to prove N number of years later that there was any ROI on the project. So Shay Sayed has been working in healthcare AI since before the LLM era, when he was in high school, I will note. He's been embedding them into clinical protocols, training nurses to interpret outputs, and more recently advising health systems on which AI tools to actually deploy. We talk about all the things that you are going to run into if you are at a startup trying to identify patients and pluck them out of a population who are at risk of a specific bad thing happening that ideally you get reimbursed for. So these are going to be hard things like fucked up data schema, which I believe is the technical term, the costly, both in time and money, iteration that it takes to actually train a model, and the fact that where you start is likely not where you're going to end on the model. And above all, you can have the best algorithm, which is not true. I have the best rhythm and flow. But if you don't have the clinical ops to back it up, you actually have nothing. And you may end up having a really nice algorithm that gives you a prioritized list. And in order to hire the MD and staffing to kind of like support and reach out to these patients, you are going to have to wait another 3 months to buy out this, MD's contract. We end on the dawn of a new era, LLMs, and we talk about whether you should even bother learning machine learning basics anymore. I hope you enjoy. All right, cool. Well, on the podcast today, we have Shay Sayed. But where are you calling in from today, Shay?
Hey Alex, thanks for having me. I'm calling out of New York City, Brooklyn actually, not too far away from you.
So, Shay, let's do intros. Let me ask you, what parts of healthcare do you currently occupy?
Yeah, so currently I'm very deep into the AI in healthcare, and that ends up spanning quite a lot of different functions. So it used to be the case with the prior startup that I was working at. It was largely around designing solutions to achieve some business or clinical goal, and I'm sure we'll dive into exactly what I mean by that. It also involved actually training models from scratch, which would include all of the messy data cleanup plus model training, hyperparameter optimization, testing, monitoring when we in post deployment, training teams of nurses to be able to interpret the model's output and use it in the field, embedding it into clinical protocols. And as of late, some of my functions have shifted over to governance advisory, is what you might call it, which is things like assessments and recommendations on what AIs to deploy across a health system slash
Mm-hmm.
organization. And this kind of comes down to evaluating a lot more than just the AI itself. It's questions around certainly the technology, but also questions around compliance and data privacy and what it means to be able to retrain models for vendors. How do you think about monitoring different types of solutions?
I see. Now, you were telling me about your past and how you got into this, and there are a couple of things that I wanted to ask you about specifically. So, you wrote that you got into ML in high school. That's quite early. How did you get into ML in high school?
Yeah, it was very much an accident. It was very, very much an accident. So this was around 2016. It was maybe a couple of years after the AlexNet paper had come out, and just maybe right before ImageNet, which is when things are really starting to heat up in academia. And what ended up happening in high school was there was a buddy of mine, and we were, kind of juniors wanting to get involved with some research, and at the time we really didn't know what we wanted to do, and so here we were in high school kind of emailing every professor I grew up in Houston, so it was every professor in the Houston area on, hey, please, will you please let us into your lab and like let us tinker around with something. I think we had some like preliminary programming knowledge back then, and the person who kind of took us in was a professor of ML, and that kind of gave us our start into MLAI, and the field has just completely drastically evolved since then. But some of the I'm positive some of the old heads listening to this will recognize some of those tools and chuckle to themselves a little bit.
Yeah. I just looked up the AlexNet paper. I see a now recognizable name, an Ilya Sutskever, named
Right.
at the second author. But I did not know about this. A convolutional neural network developed for image classification tasks.
Yeah. Yep.
When I get famous and build a company in my name, it's going to be called AlexNet.
That's a great idea for something that's a little, let's call it, well, maybe facetious is not the right word,
It is facetious.
yeah, it is. I suppose it is facetious, isn't it? But it's like, yeah, it's a little nod to kind of where it all started. I mean, it started way before AlexNet, but I think AlexNet was definitely a milestone.
I won't spend too long on this, but I just got to say that is quite unique. Like when I was in high school, I got really into Dynasty Warriors, the video game, and
Yeah.
and Madden. Do you ever? It's like a, I don't know, it's like a Einstein or like Carl Frederick Gauss sort of thing. Like you would ask, if you ask them like, hey, why did you get into that specific thing? They would just say there was no other thing to get into. Like it just made sense to them. Were there any like options for you, or were you just like, no, ML is so interesting, regardless of what age I am going to go pursue this.
I think once we accidentally got intro to the world, it definitely seemed a little magical. And it seemed very magical during my college years as well. And so, which is one of the reasons why I decided to pursue it in college and try to do my PhD, which I didn't end up doing. But I think when it's a good question with options. I think there's definitely a world in which I would have done something in one of the other sciences like chemistry, or maybe not physics, but I think chemistry was another strong contender, and so it's very, I think it's very much possible, and I would have been very sad if that was the case, because I did very much enjoy my time with the academic community in college as well, and I continue to. So yeah.
Yeah. And then, okay, so, ML in high school, research in college, PhD, then you dropped out and joined a hedge fund, and then you found out, oh, markets aren't my thing. But then you won the, like, CMS challenge, just kind of like a team with a dream. Tell me about that.
Yeah, it was when I joined the hedge fund, and I wasn't there for too long, and the kind of options I had after that were, I found myself going down one of two paths. I think one path was something that felt a little bit more altruistic, if you will, and so I was definitely, I was talking to some healthcare companies, I was talking to some climate companies as well at the time, and then I had this offer from a healthcare AI startup. It was a seed stage startup based out of Austin, Texas. I think at the time they had something like 6, 7 people. And then the other option I had on the table was actually a sports betting company,
Ah,
and so two wildly different options. And I think with the sports betting thing, it's kind of another fun thing. Guys like, sports are fun, and so I was like, oh, let me go apply my quantitative skills to something that's a little
right.
bit more lighthearted, and maybe I'll get to go to like a Rockets game or something like that. Wouldn't that be cool? And the thing that was really attractive to me about this particular startup is that they had an approach to machine learning that I felt like I had not come across before. The name of the startup was Closed Loop, and it was a healthcare machine learning platform for all kinds of healthcare organizations, largely health systems and payers. And the interesting thing about the platform that I saw immediately was this idea of being able to build really complicated features from raw data and versioning and tracking them before you train models on them. And I think that is actually, at the time, that was a huge bottleneck when it came to doing effective and quick machine learning. And the sort of approach and design principles that I saw, almost immediately really grasped me. And so that was one of the reasons I decided to go with this particular startup. Now, maybe 2 years after being there, CMS launched this AI Health Outcomes Challenge. It was this $1 million X Prize. 2 rounds. The participants were folks like Geisinger, Mathematica, Mayo Clinic, a lot of other big names that you might recognize if I could remember their names. We kind of gave that particular challenge our all, and the interesting thing was that our platform was almost amazingly built to win this challenge. The challenge was the CMS had given participants, I think, millions and millions of rows of Medicare claims data on patients. And what they were asking the participants to do was risk stratify patients across maybe 13 to 15 different types of outcomes. So it would be things like unplanned hospital admissions, it would be risk of hospital acquired infections, it was risk of maybe acute heart failure was one of them. And I think that list is still out there. But that was one portion of the challenge, and then the other portion of the challenge was the interpretability piece. So how do you take this risk stratified list now, and if you were to pass it over to a clinical team, how do you expect them to actually use the model's outputs in their operational flow such that you extract clinical value from the model's predictions? And so those are the two big pieces, and once you break down that kind of second piece, you can also get into things like bias and fairness. So it was a pretty hefty competition. It probably took up more than, I want to say, probably more than 3 months of our time, and in the end, we were judged on performance and as well as maturity of the solution in terms of how feasible it is for folks to be able to replicate this across different organizations in healthcare, and we ended up on top, and that definitely gave us a lot of recognition at the time, helped us move along with certain kind of big customers.
Yeah. In my head, this is kind of like the proxy that I have is the Netflix prize that they did, I don't know, however many years ago, right? They were like, hey, we've got some machine learning algorithm or machine learning's algorithms that recommend things for people. And from a layperson's standpoint, if the algorithm is good, if the algorithm is excellent, people will just keep on watching and watching and watching and watching, right? Based on the last video or last piece of media that they watched, they might like this piece of media. And the kind of like yes or no signal on that, the reinforcement is if they watch the entirety of this thing, or I don't know, call it 80%, then we will count that as a win for this algorithm. And obviously it is not as simple as just saying that, chaining that over and over and over again. That's why you need like machine learning. But is that a functionally like good analogy for this outcomes challenge?
Yeah, absolutely. I think it's a really good analogy actually, because I think that challenge also, not only was it a challenge in designing the algorithm that does the actual recommendation, that I think it was based off of it's some matrix reduction based method, if I remember correctly. But that's the actual kind of academic design of the algorithm that does the recommendations. I think that was kind of one key thing that came out of the challenge. But the other really important piece that ended up coming out of the challenge that took effect maybe 3-4 years down the line was the amount of engineering that you have to do to handle the level of data that you want to feed into the algorithm. And so in
Yeah.
that sort of it kicks off those two things, and maybe the second one gets a little bit less recognition. Yes, absolutely.
Okay, let's put a pin in this. I think we will probably pick this up later, but what I'm storing away in my memory is basically like me as the layperson, I'm just thinking, oh, algorithm good or algorithm bad, right? And there's probably like some percentage scale. But what I'm hearing from you is not only does it matter if the algorithm is good or bad, but there's also the how likely or how feasible is it to be implemented by a team of engineers and constantly like fed the data that it needs in, and the kind of like output that comes out being fed back in and like constantly reinforcing the goodness of the algorithm. That's its own separate, maybe even like harder challenge. Is that
Absolutely.
accurate?
Absolutely.
Okay,
Yeah,
cool.
absolutely. I would 100% agree that it is probably the harder challenge than
Okay,
implementing the algorithm. Yeah.
great. I think that will take us to our next section, which is I want to ask you, what is risk stratification, and
Yeah.
why should we care about it?
Risk stratification is definitely it's a loaded word, and I think it's something that's existed for several years now. And in my head, the way that I think about risk stratification is very simply ranking patients based on some probability of them experiencing an adverse outcome. And so it is essentially a list of patients, highest risk to lowest risk. Where things get really interesting is what kind of risk are trying to identify? What is this particular adverse outcome that you're really interested in sorting people by? And I think that is the bulk of the definition.
Okay. I
Right.
do like starting there, right? Like at its most simplest in the explain like I'm five, it's payer, you have a million covered lives. You
Hmm.
want to know who is the number one out of there to have the most risk of a, call it, I don't know, back in my payer days, NICU situation, right? Or the highest risk of a NICU stay. And so, heuristics wise, you might say, well, we can cut the list in 50% because men don't have a chance of a NICU stay, although maybe the families of those men may. So, maybe that's not even a good heuristic. But then you can also say, well, like if we are looking in the next year, then people who are not pregnant, maybe we have a lower chance of a NICU stay for them,
Hmm.
and so but that's just like heuristics.
Right.
There's
Right.
jumping into how do you actually choose between who is sixth on this list and who is seventh on this list? That is the area of machine learning and risk stratification. Or, excuse me, that is the area of risk stratification, and machine learning is a tool by which we can get that risk stratification.
Yeah, absolutely. I think you put it really well. I think what you're alluding to there is this idea of exclusion criteria, right? And so if you're looking at who might have a NICU stay, well, certainly you want to exclude everyone who is not pregnant at the moment in time. And so men are an exclusion criteria for this particular list. Another fun example would be, let's say you want to risk stratify the restaurants in town that your girlfriend will be happy that you take her to.
Yeah.
And so you will exclude everything that is part of a particular cuisine because you know that they don't like a particular kind of food, right? So that it's not even in the question of this particular outcome that you're trying to identify in these restaurants. And then now once you kind of hone in, how do you select between, well, who should be two or three? What are the criteria? Is one of the criteria going to be distance? Is another one going to be cost? And those historically have been based off of heuristics. So like, what are some of the really big, kind of very popular, well-known risk stratification algorithms? So Charleston Comorbidity Index is a really popular one. It's maybe you're right. It's like it's 10 different conditions that you take a look for this patient. It's based off of clinical data. It can be done very easily off of claims data, and you're looking for things like their let's see, what are I think the components of Charleston comorbidity are going to be things like Let me just look it up really quick.
I'm seeing six points on the highest end of the scale is a metastatic tumor or AIDS. Something that gets that is still on the list that adds to somebody's points total. But on the lower side is a myocardial infarction, which is a heart attack, right? I think. Congestive heart failure, diabetes, dementia. Okay, so maybe more like chronic things. Well, I guess not a myocardial infarction. That's acute. But yeah, so maybe, again, in my layperson's understanding, is like, hey, if you had this thing, likely you are going to have more things. And some of them are a lot more intense and dangerous than others, such as AIDS or a metastatic tumor.
Absolutely. Yeah, absolutely. And this was I forget the exact history of how they did this. They might have taken a lot of claims data and built a very simple linear regression model on top of this data to say. So the process probably went something like this. It may not be exactly true for this particular index, but this happens quite a lot, where they get a team of physicians or clinical informaticists, and they will say, okay, let's identify maybe 20 to 30 different categories that we care about risk stratifying by. So the purpose of the Charleston Comorbidity Index is to predict 1 year to 10-year mortality, right? So that is the definition by which they are risk stratifying. Now, clinical informaticists and physicians took a look at this goal and they said, okay, I think based off of, if we want to predict 1 to 10-year mortality, but if we want to predict mortality, then what are the categories that we really think we should be considering? And they came up with, okay, well, solid tumors is a category we should check for, AIDS is another one we should check for, liver disease, and we should check for leukemia, and so on and so forth. And either based off of a linear regression model or just simply based off of heuristics, there was a point system attached to each one of these categories that will now rank this patient. And so the index will pop out a score for the particular patient, and that score, based off, we were talking about this, gets sorted.
Higher is
now
worse.
You have your sorted patient. Yeah, exactly.
Okay.
So this is a really famous one. Another famous one is like Johns Hopkins is a really famous one called the ACG system. And our thesis was that these rules-based indices are not optimal, and the conversation that we would have is we would show what would happen if you allocate your resources. By allocate resources, I mean you have teams of nurses reach out to patients using the Charleston Comorbidity Score versus using a machine learning model. And what we would want to show is that using a machine learning model, you're actually a lot more precise on who you end up reaching out to. You do more with less, and you should expect to see better outcomes.
There's a concept called premature optimization that I've heard of that I think feels appropriate here, where the way that I think about it is just if we think about a spectrum, right? I'm on the most novice end of the spectrum, where I was like, okay, here are the kind of like exclusion criteria or the places that I would look to start risk stratifying in the case of a NICU, right? And I'm not a doctor, not even close. And so, but I would have tried my best to say, hey, let's like rank based on some of these criteria. What I heard in the Charleston is that they took a panel of experts who were quite experienced and good at what they do, along with clinical informaticists who also know from the data side. And they said, okay, let's we've got some hypotheses here, and we have these like labels, right, by which we can start to explore the data. At the ultimate end of this, or maybe even off the spectrum, is basically we're going to throw a bunch of data into this giant ass computer with a bunch of like chips with threads that can all like go in and out of each other, and we're just going to ask it to look at the data from a bunch of different standpoints. And our bet is that is going to handle the cases like that is going to look through the possibilities of metastatic tumors and AIDS and diabetes and et cetera, but it is also going to find all of the other things that these experts did not have the time to think through. And who knows, maybe those will outcome in a more effective like algorithm. Is that okay? Cool.
Yeah, that's absolutely accurate, and it becomes a lot more pronounced once you start building risk stratification algorithms for kind of very specific things. So Charleston comorbidity is a rather broad. It has a rather broad goal, right? 1 year
Yeah.
mortality or 10-year mortality. Now, if you want to build risk stratification for a psychosis event, that's something that's a little bit now you're kind of you're constraining the specificity of the outcome, which I think we can talk about, whether that's a good thing or a bad thing, and why might that actually be useful. But now, once you start constraining the outcome and getting more and more specific, now all of a sudden you will want to build several risk stratification algorithms,
Mm,
and now the amount of time that it takes for someone to do that manually it just ends up exploding, right? And so
yeah.
it's certainly not feasible to kind of build heuristic based risk stratification across all of the clinical operations that you might have ongoing.
Yeah. One thing that I always try to ask is who cares about this thing, right? Like I boil the giant world of healthcare into patients, payers, and providers, which is not an accurate model of the world, but it is probably my favorite so far. So I think payers, we talked about, right? Like basically I want to know who's riskiest in the best case so that I can reach out to them and try to divert them into less costly places of care. In the worst case, which it needs to be said in the United States of America, is so that I can laser their asses and get them like out of my policy, so I do not have to like deal with them. Providers, yeah, I think they want it from the care standpoint, right? I am a busy doctor or nurse or whomever, and I need to know. I need to be able to triage, right? Like in the hospital, I used to be able to triage in person, but now with virtual, with phones and emails and messages through Epic coming in, I really have no way to actually triage these people meaningfully. Anything that I'm missing there?
No, I think that's largely accurate. I think those are two main motivations. I think I would also add to the triaging aspect is when you end up having organizations that have multiple types of facilities, by which I mean you have an organization that runs both an acute hospital and a skilled nursing facility and a hospice. A lot, I think that triaging is not only happening inside of the ICU, it might also be happening to figure out how you should be handling transitions of care across all of your different facilities as well. And then I would add from the patient side, I think risk stratification is also useful to you because it ensures that if you are a good fit for a certain intervention, that you are being accurately bubbled to the top. And because the alternative oftentimes, unfortunately, will be that it will be up to discretion otherwise, right? Some people will get this particular intervention, some people will not, which inadvertently might end up leaving patients who really need something, and then maybe they need it more than others, out of actually getting this particular intervention delivered to them. And so I think that is something that's useful for patients. And then on the flip side, it's also making sure that if you don't need something, then you are not recommended for, right? Especially if the outcome of the intervention that this risk stratified list is looking to inform is something like a biopsy. Well, now, if we can get a risk stratification method that is far more accurate, this might even save you an unnecessary surgery.
Yeah, yeah, a very invasive one. And I also have this sense of like, over testing often tends to lead people down this rabbit hole. Just like, oh, let's just check this to be safe, right? And then they find something odd, and then hey, let's just check that to be safe, right? And then there's no once you get kind of like trapped into the U.S. healthcare system, almost like quicksand, it becomes much more likely that you're going to get pulled down into more and more tests and more diagnostics. Yeah, cool. I want to ask you about actually building this. So that this goes back into what we talked about above. We talked about there's the algorithm, but there's also the actual like implementation of a self-building, self-monitoring, self-like quality scoring algorithm. And I will also pencil out kind of like what we talked about earlier, which is one, the zeroth order thing maybe is the data. then the second layer is the model itself. And I'm going to just attach to that the actual implementation of that. And then there's a third thing that you mentioned, I guess fourth in this list, going back to the outcomes challenge, which is around the interpretability of that data. So can you tell me about this you may start wherever you like, but I would like to tackle all four.
Yeah, absolutely. When it came to building this platform, I think that the components of the platform that I thought were particularly unique and the most difficult is that initial data layer. And the reason for that, and just so folks understand, this was pre LLM, so we were not exactly working with textual data, although I think we had the capacity to do, but there was plenty to do with just tabular data. And the tabular data that we would end up working with would be kind of across the gambit. It would be claims data, it would be EHR dumps, it would be nurse flowcharts, things like vitals, certainly SDOH data, ADT feeds. Whatever you can kind of imagine in the world of tabular data, we were working with, and the challenge
Now, real quick,
brings.
what is the difference between textual and tabular data?
Yes. So textual data, you can think of clinical notes. Just words as you would read them in a book. And tabular data is data that can be kind of opened up as an Excel sheet. So columns and rows is kind of what I mean when I say tabular data. And the thing with tabular data, which is very much a problem that still exists today, is the schemas that you end up that different organizations will use are wildly different. So payer one will have a wildly different data schema than payer two. And what I mean when I say data schema is the way that they've designed their tables, how they're holding onto and where they are holding it is wildly different than another pair. And that is actually a fundamental problem that makes all of this very difficult, because what it now does is it requires whoever is trying to build features on top of raw data to reconcile both of those schemas into kind of one standardized schema, which is very, very difficult to do when you're working with kind of millions of rows and hundreds of tables.
Yeah. One job ago, before my job at Out of Pocket, I was actually working at a commercial real estate company doing database migrations as a product manager. And oh boy, that was hard. And then I want to say 3 jobs. Yes. 2 jobs before that. I was also at a analytics SaaS startup. And so I have a passing understanding of this stuff. I'm going to try my best to explain. So one example, probably the easiest example of schema differences and mismatches between potential payers, right? You at closed loop, if you are lucky, you have 2 contracts with 2 different payers, and maybe you want to try and join their data, and you would anonymize everything, right? But it would be like, hey, this is for the good of everybody, right? Bigger data set. But one payer calls their first name, puts their members' names into first name and last name. Column A is first name, column B is last name. The second payer, who knows why they would do this, but they dump it all into one column. Column A is first name, last name, full name, and that's all they give you. And that's not the hardest thing in the world to try and to fix. Maybe if, what I often think of in Excel, I would split text to column and it would just be boom, first name, last name. But then I would probably find out, within the full name, they actually had middle names, right? And so in one of the rows, all the way down, like row 5,702, there's actually 3 columns. And shoot, I didn't see that, because when I did my spot check, I just did the first 100 rows. Or it's what is it? There's somebody who's like Mexican, and they've got like 17 names that have extended the shape, the number of columns in this. So that's one version of this. Another version of this is maybe like phone numbers in one column are stored as ints or something like a data type, and then the phone numbers in the second pair are stored as floats or something. And I don't find out about that until I try to like push them together, and it's like data type mismatch. The third that I have in my head, and probably like the one that you were talking about, which is probably the hardest, is the structure of their tables and the way that they all join together in the giant, like zoomed out view of the database is all fucked up essentially. And so maybe like in one, they one thing that I could imagine is one payer calls their people table, their like customers table, members, and then on the other they call them patients or something. And there are like these minute little differences between what a member and a patient is, and you just kind of have to know what they are. And you, as the like poor data scientist who's like been dumped with all these tables, you're not going to know that, right? And you're not going to be able to reach out to the two like parties at the payers to be able to figure that out. You just kind of have to figure it out and make like assumptions and assertions.
Yeah, you're kind of you're taking me back to
Am I triggering you?
yeah, you are triggering. That is absolutely what you're doing. It's all
Lord.
sorts of like just weird quirks like this that
Yeah.
that sometimes I think they end up being the biggest blocker
Yeah.
for being able to move quickly.
So I'm continuing the thing of adding little markers to denote that we've entered the money zone. And so what's coming in is an ad read, and I can't change that, but I am going to do my best to make it entertaining, educational, and relevant to what we've just talked about. So at this point, I've probably beaten you over the head with the fact that I used to work in health insurance, mostly in the fee-for-service world. And at one of these payers, we were spinning up a primary care service inside the plan itself. And the logic was, we see a lot of members going straight to urgent care or the ER because there's a doctor shortage in their areas. And these visits are incredibly expensive to us on the payer side. And if we could run our own little primary care and make it the first port of call before triaging people to costlier settings, then that's probably good for all of us. To do any of that, we had to integrate with an EHR. And I won't say which one, but boy, was it annoying. And one of the things that I'm learning from this episode with Shay is that if you want to do risk stratification as a service, you have to do all of the integrations. You need data streams from multiple EHRs across a health system because these orgs probably got rolled up in giant PE acquisitions, and these orgs got stitched together, and everybody's running something different. So this episode is brought to you by Toboggan Labs. So if you are working on readmission risk, or really any problem where clinical data, predictive models, and care team workflows all have to come together, that's what these folks do. Toboggan Labs is a healthcare AI firm. They partner with digital health companies and health systems to build the full pipeline. That means handling the messy multi-EHR data integration, the production machine learning with the interpretability that clinicians actually need to trust the recommendations, and the tools and UX that make scores actionable at the point of care. They've built these systems across cardiology, chronic condition management, and primary care, and they bring reusable infrastructure so you're not starting from scratch. They're invested in your outcomes and not just your timelines. Find them at tobogganlabs.com, TOBOGGAN labs.com. And they have assured me that no matter how you spell toboggan, it'll get you there.
I think those are like two really good examples. It's all sorts of things that end up taking a lot of time to the point where you do end up having to go back to the data owners and asking a lot of questions. And like I'll kind of throw in some of the other examples that we would see. Like for example, one pair handles all of their claims. Let's say all of their claims in a single table, professional, institutional.
Oh, no.
Whereas another pair might have separate those out across two different tables, or maybe they might have one table for kind of one region and another table for another region. And so there's all of this tribal knowledge that not just payers but health systems will have. All organizations in healthcare will have, and I think this is certainly a problem outside of healthcare too, but all of this tribal knowledge that these organizations are operating out of when it comes to handling their data that now
Yep.
is your responsibility to move quickly with, right? So
Nobody's incentivized to let you, the person taking in all of this, have some extra time, have a couple extra months to like wrap your head around this shit.
yeah. Oh yeah.
Yeah,
And oftentimes sometimes the data owner may not exactly know why things were done in
absolutely.
this. They might not be able to explain certain things, right? And so it is it ends up being a situation where you have to do the best with what you have. And I think the good news is though is that with machine learning, when you're kind of just looking when you're looking for trends, it is okay to be wrong. And by wrong, I mean it is okay for your data fidelity to be a little off. As long as you are directionally correct, you can still uncover the correct trends, even with small little mistakes. I think when you now think about doing population health analytics on top of this kind of data where you are computing cost across a specific cohort and you need to be really accurate to the dollar for every single instance. If you like, there is no room for a certain patient having a negative dollar cost across 6 months, because that literally just doesn't make sense, except for the script that you wrote is saying that, right, there's something wrong or something that you don't understand about this data, and so you have to go back and fix all of those little mistakes. Whereas with machine learning, it's okay for the data fidelity to be a little off.
Interesting. Yeah, kind of works itself out in the wash.
Yeah, yeah, and I think data kind of schemas like Fire are helping out with ensuring that there's standardized schemas being used across the organization. I think at the time the adoption was still not entirely there, or it was kind of ramping on. There's likely other kind of issues with Fire that I'm sure we would have encountered if we used it a little bit more. But I think Fire is certainly a great effort. I think to this end.
Yeah, cool. Okay, so that was layer zero,
Yeah,
the data.
that's
Now that you've gotten all the data together, now you're on to
yeah.
the model.
Yeah, well, the thing that I think the one thing that we should probably talk about is the feature engineering. So now you've gotten the data munged to a point where it's clean, right? And some of that munging could involve things like consolidating admissions events. So oftentimes what you'll see in claims data is like separate line items for each day of a particular admission, when in reality that is only kind of one admission. So you have to do a joining, right, of rows, and that requires you to update your days of admission field, or maybe add a new column to the data. And that's not, I wouldn't call that feature engineering. I would actually just group that into cleanup. Sometimes your codes that you get might be a little off in terms of like where the dot is. That's an example of a very
Yeah.
simple
Yep.
function, right?
God.
You
Yeah.
you need to make sure things like addresses are properly, or if you have an address, can you pull up the zip code? Now you have to do things like geolocation and things like that, right? So that's kind of data enrichment, data cleanup. And the really kind of interesting thing happens when you start moving into feature engineering. So feature engineering, if we're kind of going back to the risk stratification analogy that we had earlier, was, can you rapidly create these categories that will be very informational to the risk stratification that you're trying to build? And it doesn't have to be, they don't all have to be correct, but we'll let the ML algorithm figure out what's important and what's not. But really what we want to do is build almost a laundry list of things that we can feed into this ML engine, so that the important ones can surface to the top. And so the the platform, what it would do is, for a certain patient, if you have all of their ICD-10 codes that they've been coded with in the past X years or 12 months, or so, you get to define that time frame. Um, ICD-10 categories operate at a very granular threshold, but they're all part of a hierarchy that ends up being a little bit more informational than the code itself. So there's 10,000 ICD-10 codes, but at level 1 of the ICD-10 hierarchy, maybe there's 50 categories, and at level 2 there's maybe 350 to 1,000, right? And so you're constraining the field's value. That's more useful to the ML model, rather than operating at the ICD-10 code level. Very simply, what you could do is take this person's ICD-10 codes and now expand build a table of 300 columns where each column is yes or no. Did this patient have uh, heart failure in the past 12 months, where heart failure maps to an ICD-10 category slash hierarchy. And so being able to do things like that very, very quickly was also critical in terms of iterating on models. I'll give you kind of another example of a more complicated feature. There's something called a frailty index that will output a score or a percentage, and it is based off of claims data, and it's meant to be a indicator for, well, how frail is this person. And there's a clinical definition of frailty. I think that paper is useful to take a look at. But what that paper does is it ends up looking at maybe 15 to 20 things about this particular patient. They have some very specific ICD-10 categories that they look at. An example of an ICD-10 category that they might look at is diagnosis of dysphagia. And so now you need to go, right. How do you if you want to build this frailty indicator to feed into your ML model, and one of the diagnoses that this frailty indicator uses is dysphagia, how do you build something, a kind of a feature builder that will look for dysphagia in all of this patient's ICD-10 codes, right? And so that was part of the feature engine that we had. And so I think the really key point of what we were able to do was have something that could build very complex features in about 10 minutes or so. And there was for those who want to know like technical details, there's an expression language that we had that would let us define clinical features very quickly. It would embed coding right into the clinical expression language itself. And ICD-10 codes is just one type of code. You have LOINC values, you have procedure codes, you have kind of a whole horde of things, right?
Interesting. Let me do another definitions check for you, right? Because I come from product management world, and features means a very specific thing in my mind. Features is something different in the way that you are using them. In the example that we started out with, where we're trying to find like the thing that we were trying to like risk stratify is NICU stays, a potential feature is my hypothesis of something that might be correlated with it. Is that accurate?
Yeah, absolutely. It's a great way to put it. Yeah.
Okay. And so the secret here is, hey, how quickly can we generate and like actually test these hypotheses and these features, and or multiple combinations of features, and actually see, oh, this one was good, let's pluck this one and use this in our model, but not having to respin up the entire kind of like experiment, and maybe is training run an accurate term to use here, to be able to do that as quickly as you can spin that up as many times as possible. That's actually getting you a lot of iteration, and there's some like edge there, right?
Yeah, 100%. There's I think that is a huge part of the edge, and I think you put it well. It is a hypothesis that we think will inform the outcome for this patient. Yes. Yeah.
Okay. Gotcha. Interpretability. What is that?
So interpretability is the ability to understand or justify why a certain patient was ranked above another patient, or why a certain patient was given this risk. So that is interpretability. Now that the why is doing a lot of heavy work there. There is no world in which you will truly understand why something was ranked in a certain way, and we can talk exactly about why that is difficult. But what you want is something that's for a clinician when you put this list in front of them. And if I'm telling this clinician that, hey, patient C is actually the highest risk of having a acute heart failure in the next 6 months, I also need to be able to justify that with data about this patient that is that adheres to their clinical framework of how they do clinical practice. So you need to be able to explain these in a way that a clinician will accept and sort of respect almost.
Yep. We've been running happy hours recently. This is an analogy. So we've been running happy hours, and some of these are sponsored happy hours. And so the companies who are sponsoring the happy hours, they have some opinion over who they want in the room, right? In a general alignment of incentives, they want people who they can sell to, right, at these events, and they want people who are in a position, in a decision making position, right? So that in an ideal case, they could have a salesperson talk to the CFO or someone at one of these startups at the happy hour, and the next day they have a signed contract because the person liked the pitch so much and had decision making authority that they could just do it, right? And so in our invite like strategy, we actually needed to rank people. We needed to say, hey, we think that these fit your risk or your risk profile, and we are stratifying them. And who's to say really whether a head of ops at a seed company or founding engineer has more or less decision purchasing power than a COO at a Series A company? And so, when I actually had to sit down and say, how did we actually like make this list and not say, hey, we just let Claude do it, which is actually, obviously like I input the preferences into Claude and I went back and forth and tried to break that down into specific like things that we could extract from LinkedIn and enrich, right? Like the series of the size of company, the most recent funding round, where this person is in like some made up hierarchy of junior IC, senior IC, mid-level manager, director to VP, and exec that I made up that felt right to me. Yeah. But we couldn't do a line by line. What distinguishes row 5 and row 6? Yeah. And that is the interpretability challenge that came up to me as you were talking about this.
Yeah, no, that's a great analogy. I think that is, it sounds, I'm wondering if anybody tried to call you out on why a certain prospect was placed above another one and how you kind of ended up justifying it. But it's like it kind of alludes to all of the problems that you do end up having with interpretability, even in clinical risk stratification. And I think the root of the problem is always that you're trying to make a decision making tool on outcomes that at the end of the day are uncertain, and you will never I think there are two things that are missing from a decision making tool like this, which you will never have complete control over. One is all of the necessary data that you need to make this decision, right? It's asymmetrical in the sense that you will be missing key pieces of information. So like going back to your example, you in one company, maybe the head of ops has the budget, and in another company it's bestowed upon someone else. Well, if you don't have that information, you're kind of going off of the fact that in most companies the CFO is actually the budget holder. You have an interpretability outcome for that particular row, which may not make a lot of sense. And then I think that the second thing is that the like causal frameworks are almost always unknown for complex processes, and if you had like a complete causal picture of everything that was going to contribute to a readmission event or a certain adverse outcome, then you would only be able to, I mean, you could effectively just focus in on the elements of the process and not really care about anything else. But alas, that world does not exist.
Yeah. So the next section that I want to get into is the failure modes, right? Because the premise of this is if any engineer or product manager or data person gets tasked with building risk stratification, I want them to know where it all breaks. And then we'll go into the section that I call what we would do if we could do it again. But in this case, it would probably be, we talk about Epic, Cosmos, and basically LLMs and what that means for forecasting the future in this day and age.
Yeah, let's do it. I think that'll be really fun. Yeah, so in terms of failure modes and how this would end up breaking down in practice. So let's say we get the data, we clean it up, we build all the features, we've identified some outcome that is important, build the model performs well retrospectively, and we have a reporting mechanism where maybe weekly or monthly we send out this list of patients along with an interpretability report for each one. What happens next? And something that we would see repeatedly is oftentimes the the buyer would not have a mature care management or population health strategy. Almost every buyer wants the same thing. They want to reduce costs or triage more effectively, and that's fantastic. But when you would dig in, a lot of the times it wouldn't be obvious to them even what is actually driving their costs, right? So take an ACO for an example. Is it your diabetic population that is contributing to your cost more? Is it your dialysis patients? Is it adverse events like readmissions or hospitalizations? And if you can't answer that question, and if you can't answer the question of, even if I hand you a perfectly risk stratified list, do you know what you would like to do with it? Like, do you have the clinical program or the staffing or the workflows to act on it? If you don't know what you want to do with this list, then the value proposition of risk stratification kind of falls through entirely.
Yeah. So in this case,
Yeah.
well, like the example that we've been working through is, hey, how hard it is or all of the challenges associated with figuring out of a list of 1 million people, which ones are more likely to have a NICU event. Some companies don't even know, do we even want, like, is that even our biggest cost driver? Like, it's fair to assume that it is, but then if you take into account like how rare they are, and you think about maybe how frequent diabetes and obesity are, and maybe there's a lot more cost that is driven from there. Like, we could do everything perfectly on the data and modeling side, but still not know what we are driving towards, trying to risk stratify.
Yeah, exactly. And there's a lot of questions that come out of that. So in the particular example, we want to reduce the number of NICU stays. A clinician would, a neonatologist would absolutely know how to go about doing that clinically. Maybe
so with this list of the top one person, I know what to do. I know how to reach out to them. I know what to ask about, et cetera, et cetera.
Exactly.
Yeah.
And although a neonatologist might know exactly, how to curb this adverse event if they know about it with an ample amount of time, I think what the organization still needs is now a structured clinical workflow around that framework, right? So it might be something like, okay, well, yes, we want to curb NICU stays, but to do this, we should target the moms who are diabetic within our high-risk NICU population, or we should target the moms that have poor social determinants of health. Those two kind of, call them action strategies, are very, very different. One requires a team of community health workers. The other might require a diabetes specialist to work with the family, right? And so you want to ensure that you think about that far before even considering or building this model and having this list, right? And a lot of times they happen at the same time, which is great, but you certainly cannot have one without the other.
Yeah. Okay. So maybe like, I to go to the NICU one, right? Like let's say I am now running an ACO, or the listener, right? Listener is at an ACO. If you went NICU, you would essentially be kind of like calling your shot. You would be baseball, Mickey Mantle at the bat, right? Saying, I'm nailing this one. And you have already hired an MD neonatologist. You have already hired a care team to help, like, with the MD to actually do all of the stuff that deals with outreach and supporting a patient. That is not just the MD work, when we say like practicing at the top of the license, et cetera, et cetera. In order to have hired the MD, you probably had to buy out their contract and wait 90 days for them to run out that contract, and then you hire them, and you've been ramping them. With the care team, same thing. And you also have to have this team like start to gel. And so you've already done this, only to find out, oh fuck, like, this isn't even our biggest cost driver, right? It's actually this other thing. So like, yeah, there's a little bit of, to your point of like, okay, yes, there is a list, but do you have the physical ops capability, clinical ops capability to effectively like heal the people at the top of the list or help the people at the top of the list? Yeah.
Absolutely. That is a very difficult failure mode, and it was one that we were, well, during my time there, I think we got increasingly better at. But I would often be surprised that that question would be posed back to us in terms of, hey, well, where
Mm.
should we actually be spending
Yeah.
our time? Which which is something that we did our best with, and I think there are certain use cases which are more compelling than others. So an example of one
Mm.
is ESRD patients that are stage 5 kidney disease on dialysis are very, very costly. And as part of that cost, there is, if you can identify patients who are going to go on dialysis much sooner than they actually need it. If you are able to do that maybe 6 months beforehand, then you can triage them into a pathway that helps them plan for that dialysis journey, and all of a sudden you
Yeah.
avoid a lot of costs associated with infections. There's a mechanism that is involved in placing a sort of catheter to do emergency dialysis and things like that, and that ends up being a huge cost driver for ACOs who have
They
this
have to like
dialysis population
fuse
involved, right? Yeah,
fuse vein and artery or something,
yeah,
right?
yeah, yeah, exactly. Yeah, I think it's called CVC,
Yeah.
central venous catheter or something like that. Yeah, and that's an example of well, like, there's not a lot of low hanging things, but that might be a silver bullet, because really all you need to curb this adverse event is refer them to a dialysis program just 6 months prior to when we think that they're going to be on dialysis, and that's not something that is entirely costly. I don't think you need to stand up an entirely new clinical program to do that, and those are examples of places that we would recommend that folks start off with. And so we kind of had a list of those that we would go by one, and even start to do some population health analytics to understand whether this is actually a trend driver for them or not. The other the other failure mode is cost savings are very, very difficult to attribute, right? Did costs actually go down because of your program? Did costs go down because now you have a much more accurate targeting strategy via this machine learning model? Or
Hmm.
was it kind of regression to the mean? Did you target the sickest patients and they naturally regressed towards average utilization? Or did the population shift because some members churned?
Yeah.
That
Yeah.
attribution methodology is ideally you would have a matched control group set up prospectively. But even then, you kind of might be wrong, and so you're stuck trying to tie back this savings number and prove ROI, and dealing with the fragility of that analysis.
Yeah. On the to use our just going example of a NICU like list, would setting up a control look like, okay, number one, I'm going to put in the test group. Person number two, I'm going to put in the control group. Person number three, I'm going to put in the test group. Person number four in the control group, and I'm going to essentially split the list in half that way, and I'm going to see what happens to the cost of my test group and my control group. I am not doing any of these like clinical out like operational outreaches. Is that
Yeah,
how we would test that?
at a high level, yeah, and you would see
Okay.
you would try to measure something like the costs of the control group uh, who have not gone down this clinical pathway versus the test group who has, and you would expect to see that the test group has you have some sort of savings, or fewer costs associated with the test group than the control group. I think that is probably the best way to do it, and kind of even then you start to have to ask questions like, okay, is this statistically significant? You might have to do it over the course of 2 years to actually see and be confident that your clinical program is working. And while you are running this analysis, your clinical program is evolving itself, right? And your model is evolving. So it's very, very difficult to try to attribute ROI to the
Oh,
actual
yeah.
methodology itself. Yeah.
To go back to the second section, or maybe the prior section, you mentioned that you guys had like something about versioning. Is that right in your platform? So could you like to the point that you just raised, like could you say, hey, for this period of time in this made up like ideal control group test that we've had, we actually had a couple of cohorts of the of the NICU list, and we are able to track the different performance in cost or the cost savings from these different test groups and these different versions of the algorithm. I guess that probably makes your sample sizes too tiny to be statistically significant, right?
Yeah, I think the versioning was a huge part of our platform, and we placed a lot of heavy emphasis on versioning features, the hypotheses that would flow into the models, and then the models themselves. And one thing we haven't really talked about is when a model goes into production, you want to version that production model so that when you eventually end up improving the model, you track that internally and ensure that the predictions that are being outputted, you know what model it actually ties back to so that you can have an audit trail, right? And so that gives you, what that ends up giving you is scores tied to points in time and also snapshots of patients tied to particular points in time. And I think to some extent that definitely helps with this pre-post analysis.
Okay, interesting. ROI math is really really hard and time consuming to like the time horizon on any kind of information that you're going to get out of this is probably 2 years minimum, and then you start to at 2 years you start to run into the issue of like people churning from your plan just from moving jobs or something if they're a commercial health insurance plan, or if you're Medicare passing away or something. Okay, so that's one reason that it's hard. You can't influence clinical ops, or you don't have a plan for the clinical operations pathway for the specific like thing that you are trying to reduce. And then you also mentioned you don't know what you do with the output. Like at what point do we cut it off, right? Do we not reach out to the 51st person on the list? Are there any other failure modes? Yeah, go for it.
No, and I think the inability to influence clinical operations is, I think it's worth breaking that down just a little bit more. So there's this kind of overarching question of, okay, we don't know what outcomes to try to curb, and we don't know how to try to curb those outcomes. I think that is one big issue. But let's say that we've kind of crossed that bridge, or maybe the buyer knows exactly how they want to do that. The other question is that kind of data operations within the buyer's organization may not be capturing everything that is useful to try to see if costs are even being reduced or outcomes are improving. So what I mean by that is if you have a clinical program or a care management strategy, there's multiple steps in that care management strategy. It is very much call it a decision tree, right? Does this patient the decision tree might end up looking like pick someone off of a closed loops list, give them a call. Have they answered? Yes. If so, introduce them to the clinical program, give them some time to think about it, and then then the next step in that decision tree may be call them a second time. And then now you enroll them in the program and now go step by step. It might be monthly visits to their house. It might be might be telehealth visits, whatever the clinical program actually is. There's multiple steps in that program, and it's useful to track every kind of portion of that flow, and oftentimes we would be missing that information as well. So if you end up missing that information, it gets very difficult to answer some basic questions like, well, is the clinical program hitting the sort of baseline that it needs to for this intervention to work? If you have a perfectly stratified list but you're only making 10 calls a week off of that list, you have to understand that there will be a lot of false positives in that list. So, and if you don't have that, well, then now you're stuck answering the question, well, is your list bad, or is it because the clinical program needs tweaking for whatever reason, right? And so those are kind of other questions related to ensuring that you can get the most out of AI and machine learning in your clinical operations.
Yeah. Again, it's just like that there's this fallacy of like the algorithm rules everything, right? Like, oh, Facebook's targeting algorithm allowed it to take over the world from an advertising perspective, but no, it was actually like the ad platform that allowed advertisers at scale to target whomever they wanted and give them what we're finding out to be like not actually like great attribution on their ROI for their ad dollars, but good enough that they spent that advertisers spent billions of dollars a year on the ad platform.
Yeah, I think that's a good analogy. Yeah.
Okay, last section. What we would do if we could do it all over again. And I think what we discussed in the pre-call was just I guess my hot take, spicy take question is: should anybody learn machine learning anymore, or should they just learn LLMs for this?
Yeah, that's a great question. So when folks say machine learning, the thing that pops directly into my head, I think linear, in a certain light, linear regression is a machine learning algorithm. The machine learning is also one of those words that's become quite hard to identify, sort of define. I think it broadly means learning from data. And like linear regression is a very simple method to learn trends from data. And if you and it can also be used as a predictive tool as well, right? So let's say you have a train set and a test set. You train a linear regression model on your train set. You assess its performance on the test set, and now every time you get new patients, you use the linear regression to output a score on probability of readmission or whatever the case might be. You have a machine learning process or a machine learning model set in place. What I would say is that if you take a look at competitions on websites like Kaggle, which has historically been a machine learning kind of competition-based website offering X prizes for fitting models on data. The models that have historically performed the best is something called gradient boosted trees, which are kind of very, very complicated tree-based algorithms that end up fitting thousands and thousands of trees on your data to be able to make these predictions. It's also another reason why interpretability is so difficult, because you have to now answer this question of, I have tens of thousands of computation being done on one piece of data to be able to assign a score to it, a prediction score to it. How do we take these tens of thousands of computations and distill it into a narrative that makes sense and is reflective of these computations? So you end up having to use other tools to understand the computations that you're doing. Nonetheless, I think to answer your question, neural networks, which language models are based off of, came out of the machine learning literature. And I think the answer is that you should probably learn the fundamentals if you are passionate about AI. So that would include things like linear regression, logistic regression, and clustering, and then stick to maybe gradient boosted trees and neural networks, and eventually make your way into transformers, because there's now transformers that do modeling on tabular data, and they end up being quite accurate. It is still more difficult to train a transformer model that just because there's a lot more that goes into tuning hyperparameters and things of that nature. But those are things that you end up picking up, and it's becoming more and more democratized.
Interesting. So we talked about you talked about a lot there. I'm going to try to keep up. This is going to be hard for me. I actually don't have a lot of analogies at the ready for this. But okay, so I think I started with a false dichotomy of machine learning or LLMs. And what I've heard from you is that actually they are similar, they are on a spectrum of the same technology, where ML is... Okay, we had an earlier spectrum of Alex does some dumb hypotheses about what might drive a potential outcome or event in the world, what might contribute to an event in the world. In the middle case is experts, like clinicians and clinical informaticists. And then towards here is, hey, we just got the data, and we are going to run a bunch of cycles on this to test a whole bunch of features and see, hey, there are actually a lot of strong correlations between these features and like the outcome of this data. We don't actually know why necessarily. It's almost maybe by way of analogy, it's like we can observe this thing in the world, but we don't know the like mechanism yet, right? We can observe that when we drop something, it always falls to the ground, but we don't know why yet until scientists did their thing and we were like, oh, there's this thing called gravity. And then so on the machine, so here's machine learning, and then now there's an even bigger spectrum over here, which is neural networks, which are okay. I'm not even going to try,
No,
but
but I think
they're
what you just
growths.
said, yeah. Well, what you just said when you were talking about machine learning, which is have a bunch of hypotheses and see what correlates to the ground truth or what happened in the past, right?
Yeah,
That correlate that kind of idea, that framework, it still stands. I think it can be applied to language models. It's kind of like it's not exactly a one-to-one kind of analogy that ends up describing them entirely, but what you're doing when you're building language models is that you are correlating past words to future words.
yeah,
And so you are looking for correlations. I think the one thing that transformers have, and we'll kind of get into this when we talk about ethos, is that transformers have removed the necessity of now coming up with these hypotheses. So even when you were working with machine learning, you would very much have to engineer your features, and you could do that. You could automate that. Yes. So now you're right. We've moved on from physicians and clinical informaticists trying to design features and then assign them scores based on heuristics, to now automating a large number of features and having a model figure out what's correlated. Now, like, let's not also reduce a clinical informaticist role in coming up with that
of
large
course.
amount of features. I think there are, it certainly helps when you have physicians and MDs thinking about what might correlate with the outcome and throwing that in the machine learning model. But if you can automate a bunch of features, maybe you can get to 90% of where you really need to get to very quickly. The thing that transformers have now enabled is like we actually don't necessarily need to do any feature engineering anymore, right? Just from the raw data now, the future ground truth output, which in the case of words is just future words from previous words, the model can learn the correlations automatically without any sort of feature engineering necessary.
Yeah. The thing that the mental model that I have for LLMs is the stochastic parrot, right? Which is that, quote unquote, the detractors of LLMs will say all that it is doing is predicting the word that is most likely to come based on the string of words, based on the large amount of like training that is done on Reddit and books and et cetera, all that OpenAI could get. And so what the kind of like next evolution of that is, well, instead of words, what else do we have like large data sets for that ensue one after another that we can train large, not language, but large event model, a large clinical history model that, and by way of that, it would merely predict the next outcome that is most likely to come up for this person, in which case could be a NICU event.
Yeah, exactly.
Okay.
And that is the ethos paper from Epic, right?
Yeah.
And I think it's fairly exciting, and I think you've kind of described it perfectly. So instead of words being the basis of prediction, let's have clinical events be the basis of prediction. Let's serialize this patient's history into a string of clinical events, and as a result of training this now model based off of the same algorithms that OpenAI is using, you now have something that will predict future clinical events, and you get a lot of interesting capabilities that you don't normally get in traditional machine learning with a model like this. I think we can dive into what some of those capabilities are, which the first is that previously you would have to train one model for one outcome, right? Let's say you have kind of 50,000 patients in your ACO, and you want to know, okay, well, who's going to have readmissions in the next 2 months? Who is likely to have acute heart failure? Who is likely to be a dialysis patient? If you want to know those three things, those are three separate models. But now, with something that continuously predicts future clinical events, you don't need three separate models. You just need one model. And when you predict this patient's future clinical events, let's say that we predicted like 18 months out into the future. What you do instead is you look for whether any of those clinical events suggest that there will be acute heart failure and a hospital admission that follows, or whether there is a hospital admission following a current stay that would point to readmissions, or whether there's going to be an ICD-10 code for dialysis in this patient's future. And based off of that, now you have those three kind of same indicators that you did out of these three same models. And then the second kind of really, really interesting
Real quick,
capability.
sorry, before we go back to that. So does this actually bring us back to the top of the episode where now you have to get a whole bunch of data? Because in order to train these LLMs to get to, where we are right now with Opus 4.6, Anthropic had to run bigger and bigger, more costly and costly training runs to result in these models off of bigger and bigger corpuses of data. And my understanding is that they're running out of data to like high quality data to put in there that are not already included in the corpus.
Yeah, it 100% goes back to getting more data, and I think that's one of the reasons why Epic actually has an advantage here. I'm trying to look up how did Epic consolidate their data set for Ethos, and it was something like they kind of had a lot of different health systems opt in. And so they would eventually certainly have the largest clinical event data set in the United States, if not the world, right? And so it's
and because they're all in Epic, they didn't have to do all this schema shit that you or like cleaning stuff that you had to do.
Yeah, 100%. I think that's another huge advantage as well. It's okay. So they had records from over 300 million patients, 310 health systems. And it has data from lab results, diagnoses, medication, procedures, social determinants of health. So all sorts of stuff were included. The question about doing all the schema transformations and things like that, I think it definitely gets much, much easier. Well, first of all, because it's all coming from one vendor. But I think the other kind of interesting thing here is that you can afford to have a lot more missing data when you're building a transformer like this. So like the analogy to language models is let's say Anthropic is training Opus, and there are let's say there's very few articles on the internet about something wacky like hot sauce, like maybe like hot sauce is maybe like 0.0005% of the internet, right? And so the amount of times that like the word pepper might show up compared to some other word that occupies a huge portion of the internet is much lower, but that is still kind of perfectly fine, because, and this is kind of very important, is because transformer models have an architecture where they're able to deal with inputs that are not standard. And that applies very much to here, right? So if you are looking at genomic data is going to be very, very little compared to certainly like diagnoses and medications. But you can still have, a transformer-based model that trains on genomic data and also outputs predicted values of what this patient's genomic profile might look like. Of course, you should definitely do testing to make sure that what you have is accurate. But it might end up surprising you because the kind of the schema no longer needs to be very standardized, and previous machine learning models were very sensitive to missing data, whereas transformers are a little bit more robust.
Interesting. Okay. Now, you were about to say the second really interesting thing.
Yeah, the second really interesting thing that I think transformers gives you for risk stratification is this ability to ask. You can now ask the question, well, what happens to this patient if I do X instead of Y? Let's say we're going back to the NICU stay example. You have a transformer model that's trained on a lot of clinical events, and this includes data on NICU events. And so you take a pregnant mom, you pass it through this model, you have this mom's past clinical history, and now this transform model is outputting future clinical events. And you ask the question of, well, how likely is a NICU stay based on this model's inference? What you can now do is modify your input and run two different cases. So modify your input so that in one hypothetical scenario, you say, I want this to enroll this mom in a social worker led CHW based program where we refer them to a social services in their community and see what that does for their probability of having a NICU stay. In another hypothetical scenario, what you do is you say, okay, I want to refer this particular person to a diabetes care management program. And how do you represent the two? Well, maybe you can represent the two by procedure codes. Like maybe there's a procedure code related to social worker related programs, and maybe there's a procedure code related to diabetes based care programs. But what you can do now is see the feature output in each one of those two quick cases and see whether the probability drops in any one of those cases, and that can actually help inform decision making for the team who's figuring out what to actually do with this patient, because that is that is something that it was not possible with traditional, or I think not possible is a very strong word. I think it was rather maybe difficult,
technically infeasible or something.
Because
you would have to like queue up another like hypothesis and like feature and like machine learning run to say, well, what if?
What if? Yeah, exactly. And we'll kind of see if that ends up being useful and picked up by the clinical community or decision support tools in kind of the coming years.
Are there any companies that you're watching or thinking of starting in this space?
Interesting. I've actually been leaning and learning a lot more about robotics lately, and I think it's what my time in AI has sort of. I think the biggest frustrations for me when it came to implementing AI into clinical workflows was this last mile problem. So you have AI that can ambiently flag a bunch of things like, hey, look, this patient's likely to have a readmission, or we think this is a high fall risk individual. But the last mile still ends up falling through the crack quite often. It has nothing to do with people not being good at their jobs. It's more along the lines of there's a lot of competing priorities and things will always fall through the cracks when it comes to operational execution. And I think that is one thing that robotics actually offers that a language model or a machine learning model may not offer. I think maybe a language model can offer that for workflows that are entirely text-based. But when we are thinking about bedside care on the actual floor of facilities, or maybe even in a situation like home health, that last mile problem is something that will need tools beyond generative AI, and kind of robotics is the kind of next beacon to help tackle that.
Cool. All right, Shay, I think let's bring it to a close now. We've been talking for almost 2 hours, and this has been so illuminating to me. Thank you so much for joining.
Yeah, no, thanks so much for having me, Alex. This is fun. We're happy to talk more if we need to. Let me know when you've bought a couple of GPUs and we can start training a couple of calls together.
And then I'll get a robot too.
Yeah. Awesome. Yeah. No, very cool.